Good afternoon, everyone, and thank you for joining us today. I'm really sorry we were running a little bit late, and we're trying to onboard our guest, Dr. Nick Dattani. It might take a few minutes, but we thought we'll start, and Nick will join us shortly. So I'm Tamara Djuretic. I'm Director of Public Health in Barnet Council and at the Borough 3, and we have here Julie George, who is Deputy Director of Public Health, Nick Dattani, who is our local GP and COVID lead for Barnet, will be joining us shortly. He is a GP in Millway practice. So I'll just start by saying that what we would like to do in the next hour or so, we want to start with a brief overview on the pandemic, on things that we're currently doing. Nick, when he joins us, will talk about a vaccination program. And in those introductions, we will try to pick up as many questions as we can that you've already posted to us. And then we can open up for further questions and discussions. So hope you all enjoy a session. We are trying to give you as much information as possible, but if we don't have answers to some of your questions, we would be happy to take it back and follow it up, because the situation, as you know, is developing rapidly, and we're not always on the top of every single detail. Right, so let's talk about the pandemic. In Barnet, we are seeing a decline in infection rates. We still have very, very high infection rates, but at the moment we're seeing about 650 per 100,000. So it's about 2,500 to 3,000 people testing positive. This is the decline compared to 1,000 per 100,000 about 7 to 10 days ago, but it's still 400 times higher than what it was in October. This is a second peak, and the second peak we think it's due certainly to infection spreading faster. We've got winter here, and viruses like winter, if you like, and they multiply, but it's also people spend more time indoors, and it's more likely to be spread that way. Certainly you've seen in news, and there's lots of discussion about new variants. So there are a number of new variants, and we do test for all new variants. We think that about 60% at least of what we know of Barnet infection is due to new variant. It's important to say that maybe it is a little bit more transmissible, and there are studies to look into it, whether it's just transmissibility of the virus or whether it's also coupled with behavior and indoor gatherings, but it is making more people infected, and it's not more severe in any way. So the fact that we have more people in hospitals is sheer quantity of people being infected rather than severity of illness, as we see now. In terms of what we're doing at the moment, so we've got a number of activities. Certainly we are continuing with testing, and we have two strands of testing. We have testing for symptomatic cases, which is called PCR, which is throat and nose swab. And we've got a number of sites across the borough. We've got about 3 sites, and then we have further mobile units. And also we've got something called rapid test or lateral flow test, which is a test for asymptomatic people, so people who don't have symptoms. And we have community testing sites in Barnet, but also this particular program is run in schools and is run in care settings and in health and social care workers. It picks up, in fact, people who are infectious, but it's not as accurate as PCR. We also have COVID champions, about 160 across Barnet, and I know some of you might be here today, so I just wanted to thank you for all the enthusiasm and work that you're doing. Julie will talk more about it in details. We also have launched a contact tracing in December, enhanced contact tracing to support our NHS test and trace. and now our contact tracing rates have increased as a result of that. Julie will pick up a bit more on this. And then certainly public health campaigns. We've just launched a campaign that we call it COVID Can Cost You Everything. And why we're launching it now when rates are declining is because now more than ever it's really important to understand that lots of people are still very infectious and infected, and even because we do have a vaccine here, but vaccine at this moment in time we don't have evidence it stops transmission. Therefore, it's really important to continue with social distancing and infection control measures. And then in terms of vaccination, hopefully when Nick joins us, he can talk more about it. If he fails to join us, I'll pick it up afterwards. So what I would like to do now is hand over to Julie to talk about different elements of our response.
Thank you very much. Hi, as Tamara said, I'm the Deputy Director of Public Health, and I've been working closely with Tamara and others on a couple elements of the programme. I thought I might just start quickly with giving a bit more detail about the testing that we have on offer. And there's already a couple of questions in the chat about that, so I'll address those while I'm doing, and then talk a little bit about our local contact tracing, if that's all right. So as Tamara said, we have two sorts of tests that are available for COVID. One is for symptomatic people, it's called a PCR test, and we have 3 local testing sites now, which are in Fenella House Car Park, Watling Community Centre and Osage Lane Car Park. We also have mobile testing units which rotate across 3 sites across Barnet on a weekly basis, and which ones are available on which days is available on our Barnet website. But between them, we can have over 4,000 capacity for over 4,000 tests a week. However, sometimes when people log on, they may be suggested that they go somewhere else, either that's closer to their home or further away if the testing capacity is exceeded. So occasionally people are asked, particularly when there's a high number of people being asked to booking tests, are being told to go further away. Unfortunately, we have no way of in our systems to actually be able to tell that our local residents are being sent further away. So we do welcome if people tell us that that's happening, so that we can, you know, lobby on behalf of local residents. In terms of rapid flow, at the moment, the 3 sites that we have up and running are in Colindale Library, in Burnt Oak Leisure Centre and in Hendon Leisure Centre, and we're looking at another site, hoping to have that up and running relatively soon in East Barnet, but still finalising where exactly that will be. But at the moment, because people are meant to be staying at home, we're focusing on encouraging people who need to be out and about, particularly for work, to book into those sites, because it is a less accurate test, but it is able potentially to identify some people who are infectious and then who may not be aware because they don't have any symptoms, and enable them to self-isolate and not spread it inadvertently. One of the comments on in the chat is said that lateral flow tests have been banned by the government. That's not correct. What they have done is they have currently paused their policy of actually doing lateral flow testing in secondary schools for people who are contacts of a case. So normally what would happen if you're a contact of someone who has COVID, you'd be asked to isolate for 10 days. And they were proposing that students be allowed not to isolate so they could continue their education in school, but instead do a daily lateral flow and be able to come into school if it was negative. And they have paused that. In fact, last week, in advance of the government announcement, we advised that we did not want our schools to pursue that because Tamara felt that was it wasn't sufficiently evidence-based and had some risk. And I think one of the things to understand about the reason for that is that's using the lateral flow device as what might be called a test to enable an activity. And in general, we're advising against using the test in that way. So it shouldn't be used to help you do something you wouldn't otherwise do. We're trying to make it the rapid tests available to people who are going about their business and have to do certain things to possibly identify things they would be doing anyway, and try and identify a few more people that are actually infectious. So I'm sure there'll be more questions about testing, and I'll pick them up as we go. Just a couple words about contact tracing. There is a national service that people are aware of for contact tracing, where they aim to get in touch with people when they're infectious and identify who their contacts are, and then ask them to isolate. Since December, we've been running a local service which complements or supports the national service. So if they have been unable to get a hold of people within 24 hours, they pass the case to us, and we attempt to make contact. The local service has some improvements over the national service in that people can bring us back, which you cannot do with the national service. So you can, if we leave a message, you can actually we can get an inbound call. We also email and text everyone as soon as we know they're on our list to ask them to get a hold of us. And we have an easy access to interpreters. And we also drop off cards if we haven't been able to get a hold of people, saying we are trying to reach you, please call us, we'd like to speak to you about your contacts. So we are doing reasonably well in terms of we managed to get through and speak to about 40% of the cases, which is actually, you know, as far as local contact tracing, is a pretty high success rate. I think I'll leave it there because that's just a very quick gallop tour about some of the things we've done, but maybe back to you, Tamara, to let us know what we should be answering next. Thank you.
So thank you. Thank you, Julie. That's really useful. There are a number of questions we can pick up, but I have here a signal that Nick is online. I can't see Nick, but if Nick is online and ready to go to cover in intro vaccination, Nick, we have a number of questions about AstraZeneca versus Pfizer vaccine, potentially which one can, and new variant and how they react to it. I can pick it up that as well if you haven't got answers to those, and then also a number of questions about GP practices and communication and how members of public can be communicated to in terms of the vaccination program. So I'll hand over to Dr. Nick Dattani now.
Thanks, Tamara. Apologies for the technical issues. You can't see me in person, but hopefully you can all hear me. So just a brief introduction. I'm Nick Dattani. I'm a GP in Mill Hill in the Borough of Barnet, and I'm also a clinical lead on the North Central London CCG in the Directorate of Barnet. So thank you, Tamara and Julie. So really what I wanted to cover is about the two vaccines that we have in the UK. And as you know, we've got two vaccines that have been approved in the United Kingdom, the Oxford AstraZeneca vaccine and the Pfizer vaccine. And approval, as we know, has been given if the UK regulator, the MHRA, is happy that the vaccines are safe and effective. And a lot of patients have asked, well, what's the differences between the vaccines and how do they work? And as we might know, the Pfizer vaccine uses bits of genetic code to cause an immune response, and that's called the mRNA vaccine. And it doesn't alter human cells, but merely presents the body with instructions to build immunity to COVID. And if you look at the other vaccine, the Oxford AstraZeneca vaccine, that uses a harmless virus altered to look a lot more like the pandemic virus. Now, vaccines contain, lots of different ingredients, but actually they're really safe and stable and have been tested quite vigorously in the UK amongst thousands of people. And as we know, nearly 5 million people in the UK have now had their first vaccine, which is excellent. So if I bring it into the actual borough and how we've done in the borough, we've actually done remarkably well. So the borough is split into primary care networks, so PCNs, and we've got about 7 different pockets of Barnet and around. And at the moment, I can confirm that by Friday, so by tomorrow, all of our care home patients will have been vaccinated. And I think that's really, really fantastic news. And then we have a rolling plan with GPs and our community healthcare provider, which is COCH. And for the public, that means so people like district nurses and rapid response who'll be supporting and vaccinating our housebound population. And as per national guidance, so NHS England guidance, we'll be vaccinating all housebound patients in groups 2, 3 and 4 over the next 2 weeks. The latest vaccine will be received by the 12th of February. But generally, most housebound patients might have already been vaccinated or we plan to be vaccinated next week. Now, one of the questions really has been about, can the vaccine give me coronavirus? And absolutely, we don't believe that. But you can't get coronavirus from the vaccine. And a vaccine wouldn't be approved for use if it could give you the disease it's supposed to protect you from. As we know, I've said it doesn't contain the live virus, as I've said. And one of the questions you asked, Tamara, is does the vaccine work against the new strain of the virus? And as far as we know, and of course, evidence can come out in the future, but right now what we know is the vaccine will still work against the new strain of the virus. And your immune system needs to generate a response. So generally, the protection from the virus starts about 7 to 10 days after its first dose. And as you know, we need to give 2 doses for immunity to begin. And we think again, after the second dose, 7 to 10 days afterwards, you really build up that immunity. We don't know how long for sure the protection will last, and this may vary between different vaccines. And of course, there's other vaccines in the world, for example, the Moderna vaccine as well. But what we do know is that definitely likelihood that you're going to have months, if not years, of immunity. But it could be that actually we need repeat vaccinations in the future. But that's where research comes in and where we're studying this closely. And we don't know all the answers to the longevity of these vaccines. But what we do know now is that they are here to protect us, and both of the vaccines in the UK are very, very effective. And Tamara, you asked, what are the efficacies of these vaccines in the UK? And what we know from both of these so far is that after the second dose of the Pfizer vaccine, it's about 95% effective, and with the Oxford AstraZeneca, about 90%. So they're very, very similar. And there's no real differences in, to say, oh, I should have this vaccine versus the other one. I think if you're given either of the vaccines, it's absolutely fantastic. And I think they're both highly effective and highly protective. And so I think actually we shouldn't be saying, I don't want this one, I'm going to wait, or I want this one. We should be absolutely with open arms gearing up to accept both of those vaccines. I'll pause there because I can't see the chat bar for any other questions.
Thank you, Nick. So I'll pick up on a few questions. Let's stay with the vaccination for now, and then we could move to different areas. So thank you very much. That's really, really useful. I think it's really important to understand that the vaccine trials so far looked at the effectiveness of the vaccine and concluded the vaccine is effective against developing severe illness and death. What we don't know yet is whether the vaccine stops the transmission. And the other thing to say is we also, when we looked at the trial studies, at that moment in time, the Pfizer vaccine was showing about 90% efficacy against severe illness and death at first dose after 12 to 15 days. And then second dose would boost it up to 95%, whereas the AstraZeneca was slightly less. But they use different methodology, and it all varies if you look at the different studies. So there is Israeli study as well, someone put in a chat, because Israeli has an agreement with Pfizer to do a research and collect all the data. Not all countries do have that. They are publishing different studies, and what I can tell you is that there are national discussion between UK and Israel to understand the data better, because what we're seeing here is not necessarily exactly the same as it is in Israel, but we are monitoring everything across the world very, very carefully in order to, if needed, change of policies. But public health advice was to try to vaccinate with the first dose more people than rush into the administering both doses. This might change as the information increases, or if we get different information contrary to this. But at this moment in time, we are relatively confident that it's very effective in preventing severe illness and definitely deaths. So I think that's good news. There was a question, Nick, on which I think it might be, if you pick it up, on allergies. And so who would discuss with residents what allergies they have before the vaccine is administered? And also, is there a difference, do you know, between Pfizer or AstraZeneca in terms of allergic reactions?
Thanks, Tamara. Really good question. So the Pfizer vaccine, there are a couple of contraindications, but very far few. And the biggest one is anyone who's had anaphylaxis to another vaccine. So we're not saying it's anaphylaxis to, for example, strawberries, but what we're saying to another vaccine. And patients will generally know that, and that will be in their medical records. So that when we invite patients to have their vaccine, we will have their medical records. And if the patient is being invited for the Pfizer vaccine, we'll be making sure they do not have a history of anaphylaxis. Whereas with the AstraZeneca, we don't need to worry about that. In terms of allergies, what we know from both of the vaccines is that there's a list of ingredients which people might be allergic to, but unlikely. Now, what I mean by that, for example, the ingredients in the Pfizer vaccine, there's a long list. Things like sodium chloride, sucrose, water, potassium chloride, cholesterol, all these types of ingredients. Most patients won't know if they're allergic and are very unlikely to be allergic to them because they're contained within multiple different things that we use all day, every day and all day. So the likelihood of allergy and anaphylaxis is incredibly rare and unusual for these vaccines. The only other consideration to be aware of if somebody's on warfarin and their INR levels, which is to see how thin the blood is sort of very high, then that might be a contraindication for receiving the Pfizer vaccine. But again, we're talking about very small numbers of patients in these groups, and GP practices will have access to a medical record. So if you're invited for the vaccine and you're unsure, then you should speak to the GP practice. The chances are, pre-inviting patients, we've already done our homework and looked at your medical records and made sure that the vaccine we're inviting you for is safe and that you're not going to suffer side effects. And then just to add to that, Tamara, one of the questions about what are the side effects as well about these vaccines, and like all medicines, vaccines can cause side effects, as we know, and most of these are quite mild and short term, and not everyone gets them, and that's very important. If you do have symptoms after the first dose, you still need to have the second dose. Although you should get good protection from the first dose, having a second dose will give you much longer lasting protection. Now, the common side effects really are having a painful or heavy feeling and tenderness in the arm where you've had an injection, and that can last a couple of days, and we're probably quite familiar with that feeling when we've had other vaccines. Some patients can feel tired or have a headache or general aches or mild flu-like symptoms. Now, in 1 in 100 or less patients, sometimes you can have sort of a feverish feeling for 1 or 2 days, but a high temperature is unusual for most vaccines. Okay. Some patients might need to take rest after the first day, or might need to take some paracetamol for a day or two. But generally, people have been receiving the vaccine, and certainly in the Borough of Barnet, we haven't been reporting any significant adverse effects, which is really good to hear. Back over to you, Tamara.
Thank you very much, Nick. That's really useful. There are still some questions on the efficacy. So none of us is expert in those fields, but what I can tell you is that there are different studies across the world. Just wanted to re-emphasize that point. Different studies across the world looking at different ways of estimating the efficacy, and some when you see like 50%, 70%, it depends when they include people who develop illness, whether they include them straight after they had the vaccine or whether they wait until we think the immunity is definitely there, which is 12 days after for Pfizer, for example. And this is where you see the variation. I suppose, I think it's also important to say, I'm not dismissing all of this, but what's really important to say is that I think our flu vaccine is about only 50% effective, and there are other vaccines as well that are not much more effective than this one. So I suppose at the end of the day, at the personal level, it's really important that people get vaccinated. So even if they do develop illness, it would be very mild, because we do know it's almost 99% effective against deaths, and it's very, very effective against severe illness. There's lots of questions about data and how do we get data, and that is a tricky one, because there is a national data system that pulls the data together. In terms of bookings, I think we do it at the North Central London level. We have all the patients' data and we do it through there. But once people are getting vaccinated, it gets pulled up to the national level. At the moment, we have, as Directors of Public Health, only started receiving very high-level data a couple of days ago, and we are asking for more granular data on ward level and also to understand inequalities in vaccinations. We don't yet know the inequalities. We have anecdotal evidence that some care workers, for example, specifically from BME communities, are a little bit more hesitant. We are doing piece across London, but also locally as well, to talk to different communities, to understand where the hesitancy comes from, and to try to support as many people as possible to get vaccinated, because we know that it's the only actually effective protection against this particular virus. So as we get information available to us and able to publish, and we are confident that they are validated data, we will definitely share that, as we do share with our dashboard. So there is a bunch of questions about enforcement. Why are we not enforcing masks in supermarkets? So I just very briefly, we don't have anyone from enforcement team, but very briefly just wanted to say that we work very closely with police, and there are different responsibility between what local authority can do and what police can do in terms of enforcement. Our authority is mostly with the small and medium businesses, and when it comes to individuals potentially not following the social distancing rules, what police takes approach of education and empowerment before they do enforcement, and enforcement is saved, if you like, for those blatant and obvious incidences, and we've had few in pubs and some parties across Barnet. What we have done and are doing is we've got, I think, a team about 50 from local authority, and you could see them in vis jackets now across the borough, because it's a big borough. It's one of the biggest, it is the biggest in London. We've got biggest number of businesses. We try to focus them in areas where we think it's a higher prevalence, or where we have reports of non-compliance, and anyone could email us on enforcement, COVID-19 enforcement@barnet.gov.uk to let us know if they see something, and then we have a team who acts upon this. In terms of supermarkets, we have worked locally, but we also have worked nationally. Association of Directors of Public Health worked with the big supermarkets to try to enforce, to try to emphasize the importance of wearing masks, and I'm pleased to say that they have now came up with a public announcements that people will not be let in. Of course, there are those who are medically excluded, but for everyone else, masks must be worn. We also do visit our supermarkets locally and enforce messages, but we do that probably more reactive than proactive, just given the time we have. So what I would like now to do, Julie, is there is a set of questions on LFD and isolation. I don't know if you picked them up, but there's something about what's the accuracy of LFD. If people are testing positive on LFD, do they need to self-isolate? Do they need PCR follow-up? So if you don't mind taking those in a bunch, that would be useful.
Sorry, I was on mute. I didn't want to make any noise for the others, but here I am. Yeah, happy to take those questions tomorrow. Thank you. So in terms of if someone's had a positive test on a lateral flow device, this is covered in the guidance on self-isolation, which is available on gov.uk, the COVID pages. But basically it says you should self-isolate on a positive test, whether it's from a PCR or lateral flow device. However, if it's a lateral flow device test, you should get a confirmatory PCR test within 48 hours. And if that is negative, you can stop isolating. So it is clear that you should isolate if you have a positive PCR test, LFD test. And more details are in the gov.uk website. I think that answers that question. There was a question about the sensitivity of lateral flow device tests. And the answer to that is it's a little bit complicated. So there are two main sources of information on how sensitive the test is. And sensitive in this sense means how accurate is it in picking up if someone is accurately identifying if someone has COVID, if in fact they do have it. So the two sources of information is studies that were run by Porton Down, which is the main Public Health England laboratory that does these sort of tests, and then the large pilot study in Liverpool that actually rolled out general testing across the public, and at the same time as doing those rapid tests, they also did PCR tests of individuals, and so that they were able to see what the accuracy was. So in the Liverpool data, the sensitivity was in general about 40%. So it picked up about 40% of cases of people who actually did have circulating COVID in their bloodstreams. It's picked up by the PCR. However, if they were in a very highly infectious state, that went up to 66%. So it does partly depend on at what point you're actually testing someone in the kind of cycle of the illness. The Porton Down also brought through some other elements, which is that you have a higher sensitivity if the test is administered either by a lab scientist or healthcare staff. So they had sensitivity of 73, 79 and 73% each. But if they were just being done by self-trained members of the public, it was about 57%. So it does vary partly in terms of where someone individual is in terms of their illness, but also who does the test. But this is why, because it will miss, on all these measures, we know it's missing a number of positive cases, that we only use it as a tool to try and reduce some of the asymptomatic people in the population who are going about their business not being aware that they're actually potentially infectious. And we don't want to use it as like a gateway to doing things that you wouldn't otherwise do, what we call test to enable. I don't know if there are any other questions on lateral flow. I think those were the two. Is there anything else, Tamara, that I've missed?
Thank you very much. No, I think that's it. I'm trying to screen them and share.
There is one on local contact tracing, if I might answer that.
So there is one. Yes, I was going to say. Yeah. Go on. Go ahead.
So the answer is we don't. It's from Richard, and he wanted to know if 40% of people were contacted through local contact tracing. I mean, that successfully had a conversation and collected their information. When I say 40%, we obviously reach out to everyone that's on our list. We are not locally, we're not responsible for trying to get in touch with their contacts. We are this sort of small cog in a very large machine. So we try and reach the individuals that the national service can't get a hold of within 24 hours. And then when we identify their contacts, we load it onto the national computer, and then the national service tries to get a hold of their contacts to try and ask them to isolate. So unfortunately, it's not a question I can answer. If you look at our kind of rates, it does say last week, I think it was about 90%, 96% of contacts were reached and asked to isolate. I think it's important to recognize that those are contacts that the individuals have identified. And usually it's their household members. There may be a few others, but both the nationally and locally, we do sometimes struggle to get people to identify additional contacts that they might have had outside the home. But in terms of successfully speaking to people and telling them the contacts and telling them to isolate, the numbers as reported to us are actually very high. Unfortunately, we just cannot disentangle how much of that is related to people we've already spoken to. I think that's probably all from me for the moment, Tamara, so I'll turn back over to you.
Thank you, Julie. Thank you, Julie, very much. That's very useful. Understandably, we do have a lot more questions on vaccines, so I think we'll go back there again. Nick, there are a couple of things which we can pick up between ourselves, but the one there is a question about what about reports that vaccines might cause infertility or have impact on fertility, and obviously they haven't been around for that long. So what do we know about that? There is something about effectiveness against the new strains, but I can pick that up because we've discussed it recently at the national calls. Then there is something about delay a second dose between first and second vaccine as well, and our plans for like having a 12 weeks apart, I suppose. And then there is something about supply of the vaccination, and then I'll pick up on stats and variants.
Thanks, Tamara. So there isn't any evidence from trials of the vaccines that it affects fertility. As the vaccine stimulates an immune response to the spike protein, particularly in the Pfizer vaccine, if it did affect fertility, we might also see COVID-19 infections affecting this too, as the body should produce similar immune response if infected. So because we don't see that, there's absolutely no evidence that that's the case. Although it has been suggested that COVID-19 cases seem to be more severe in pregnant women, there isn't evidence that COVID-19 causes women to lose their pregnancy or struggle to get pregnant later. But what's been clear by the government, just to be safe, is that the statement is that if you are pregnant, you should not be vaccinated unless you are at high risk, or you can be vaccinated after your pregnancy is over. But if you are pregnant and you think you're at high risk, you should discuss having or completing vaccination with your GP or midwife. And that's really important to know, that there's been a lot of sort of media about infertility, but none of it's been proven to be true. We must be absolutely clear that we're presenting the right facts to one another. Tamara, do you want to add anything to that?
Thank you. No, that's really useful. Thanks, Nick. Are you happy to pick up on supply, or do you want me to talk about that?
Yeah, I can talk on supply as well. So as you know, we've had a significant supply of vaccines in the borough, and there's more supply coming forward. So you may know, or patients may know, that there's different waves in boroughs, and so different practices within the borough started to receive vaccines at different times. And some of these, as you know, were before 2021, so in December, and we're continuing to receive vaccines on a weekly basis. And nationally, vaccines are received using a push system, so that if we know a particular pocket in the borough or in London hasn't vaccinated a certain cohort, but other pockets are vaccinating a cohort lower down. So, for example, let's say that one pocket is still vaccinating group 3, but another area has moved to group 4, then we'll issue more vaccines to the area that needs to complete the vaccinations for group 3 to make sure that generally we're sort of aligned in vaccinating patients. As you know, in Barnet, we're now moving to group 4 as of this week. So from Saturday and earlier in the week, we've started vaccinating group 4 patients in some pockets of the borough. What we must realise is that Barnet is a mixed population, and some pockets of Barnet have particularly larger numbers of groups 1, 2 and 3 patients compared to other pockets, and so they're having to work quite hard to make sure that the vaccines are delivered. We also need to be aware that when we're vaccinating patients, we're maintaining social distancing, people can get there in a timely manner, and as you can imagine, some people who are above 80 might have mobility issues or might be frailer and might find it more difficult to get to vaccine sites. And sometimes the fact that we haven't completed all the group might not be in the vaccine sites gift. It might be that patients have struggled to get to the sites because, as you know, particularly when we have the Pfizer vaccine, sometimes we only get told 2 or 3 days before that the vaccine is coming, and then we've got to book people in quite quickly into those slots, and it can be quite difficult for certainly patients over 75 to always make it to their appointments. But what we're absolutely clear on is that no vaccines go to waste, and so far we've had no waste. We're overbooking patients into vaccine sites, which is fantastic, so avoid that. And patients are going to different parts of the borough as well, where there's a greater supply of vaccines. So it might be that although you've been invited to the site nearest your home, which might only be a mile or 2 away, some patients are prepared to travel 15, 20 minutes from their home or even longer, where there's more supply or greater supply of vaccines to avoid any waste. And then just to add to that, the idea would be to complete group 4 vaccines in the next 2 weeks. And as I said earlier, housebound patients should be complete also in the next 2 weeks. And by this Friday, all care home patients will be complete.
Thank you. Thank you, Nick. So just to add to that, people are asking about a local uptake, and you covered that. And as I said, we don't have a fully comprehensive data. What we do know is that North Central London has vaccinated more people than any other parts of the London. However, it's been reported across the country that London is potentially a little bit behind. And that is because our primary care networks are much bigger than outside the country. And at the beginning, we were receiving the same amount of doses, regardless of how big your population is. And Barnet is the largest population in London, and we have over 16,000 people over 80 years of age, compared to Camden, who probably has half of it. So I suppose it was at the beginning there was a little bit of disparity with supply, but now we are sure that supply will be given based on the population needs, and therefore it's getting much smoother and quicker. As I say, there are no exact data and statistics to be shared, but we are hoping to share that hopefully next week. I think at the moment it's only published nationally, and we will be validating data, and as soon as we have data, as I said before, we will share. So the other thing, it was about how effective vaccines are against new variants. So there is no evidence that both of those vaccines, AstraZeneca and Pfizer, that are mostly used in the UK, are not protecting people against the new variant. Obviously, this is all relatively new. The new variant emerged only a couple of months ago, so we are looking into it very carefully. But if anything, it would be if there is definitely some protection. What might happen is that that if people do develop, they will develop really a mild illness. And there is more evidence that after 2 doses, people will be protected against those variants. The other thing is thinking about the vaccines and the way they're manufactured. I think what we are saying is that we will go with the first phase of the vaccination, and then if vaccines need to be tweaked, if you like, they could always include new variants. This is what happened with the flu vaccination every year. And there are different variants that are looked at and put into the vaccine each year. So going forward, we don't know the longer term, but one of the potential is that vaccine would be tweaked to include all the new variants as we go along. So I think that concludes vaccination questions. If there is anything else coming up, we could pick it up. I just got a few more things that are coming up and talking about COVID-19 secure risk assessment at our testing sites. So just wanted to confirm that some of our sites are on council premises. So we are responsible for COVID-19 secure risk assessment to be conducted, but most of the testing sites, especially for PCR, are DHSC-led sites. So we're making sure that DHSC has COVID-19 secure risk assessments, and myself and health and safety team have visited some of the testing sites to ensure that this is in place, and we can confirm it is now in place. And equally for the LFD sites that are run in partnership between local authority and a event company, we also ensure that these COVID-19 risk assessments are in place, and that has been working really well. So let me just turn to right. I'm just looking at the questions if there is anything else coming up. If there is anything that I have missed, so just give me a second. Right, I think the only other one probably, so there are two questions. One is about unpaid carers, and I think also maybe just saying that Joint Vaccination Immunization Committee has published all the priority groups. So the first one certainly is care homes and health and care workers, and then people over 80 years of age, then people over 75 years of age, people over 70, and then clinically shielded. Then it goes down by age groups. In group 6, the priority groups have been recently updated to include unpaid carers. And the question here is, some of the unpaid carers are not registered with GPs. So I'll just say what we do at the NCL level, and maybe Nick might have an idea and advice, but we are trying to scope out all the groups that we know of that are potentially unregistered. So they could be asylum seekers as well as migrants who come in and live with other families. We've got homeless people that tend to have a lower registration than general population. So we're scoping out all different groups and working with North Central London to have a strategy how to get these people up and registered, and also maybe thinking whether there is something at the local primary care network hubs when they are vaccinating that people could turn up. But we haven't got a system for that yet. It would probably take another a couple of weeks before we put that together. I don't know, Nick, if you wanted to add anything on that.
Absolutely, thanks, Tamara. So as you said, it now recommends that unpaid carers who you would normally get the carers allowance, or who are the main care of an elderly or disabled person, and that's a child or adult whose welfare may be at risk if the carer falls ill, should be prioritised along with people with underlying health conditions. So, and that's really come from a lot of work that's come from campaigns and charities. So that means that unpaid carers are now in priority group 6, as you've said. What's really important is if you haven't registered that with your GP practice and it's not in your medical records, it might mean that your GP practice is unaware. And so if that's the case and you are an unpaid carer, then you should sort of send an email or contact your GP practice and speak to the reception team. And sometimes it might be that you've been asked to provide some evidence of that, because it might be that you need a letter or something from the actual patient you're looking after, and that would be quite helpful to be added onto the GP records, I think.
Thank you, Nick. That's very useful. Okay, so we will now wrap up. I would just like to thank our panelists for their time today. So thanks to Nick and Julie for being here. Thank you all very much for engaging and sending the questions in. I hope you find this session informative, and if you'd like to provide some feedback, we would be happy to have a follow-up sessions on maybe specific aspects. We tried to cover today many different aspects, but takeaway messages from myself as a Director of Public Health is thank you very much for complying with the guidelines, following social distancing rules. It's been really hard. We've been in this for a year now, going through another lockdown has not been easy on anyone, professionally and personally. Many people have lost their loved ones, and our heart goes to them. And we're hoping that there is a bit of a decline that we see as a hope and vaccine on the horizon. One thing to say as well is that we're working really hard to get through as many people as possible to vaccinate. So really no one is forgotten. Everyone who is registered is on the list and will get notification either by text or by letter or by telephone to ask them to book their appointment. So please be patient. We are prioritizing those for whom we know they are at the highest risk of dying of COVID-19. So once again, thank you everyone. Thanks Champions for asking us to come up with this session and for all the hard work you've been doing. And see you all soon. Bye bye.